Hello, let's learn about antimicrobial. What is resistance? Resistance is the ability of a microorganism to avoid the harmful effects of an antibiotic by destroying it, transporting it out of the cell, or undergoing changes that block its effects. The three possible outcomes when antibiotics are introduced are death, that is bactericidal, growth inhibition, that is bacteriostatic, or resistance. Bacteria can develop resistance to multiple drugs and antibiotics, further facilitating their spread. Now, how does this antibiotic resistance occur? High number of bacteria, a few number of them are develop resistance against the antibiotics. The antibiotics kill the bacteria causing the illness as well as the good bacteria protecting the body from infection. The resistant bacteria, some of the resistant bacteria now have the preferred conditions to grow and take over. The bacteria then even transfer the resistance to other bacteria, causing more problems. This is how the resistance develops. What is the mechanism of resistance? There are multiple mechanisms of resistance. One is in the decreased influx, increased efflux of the antibiotic from the bacterial cell, then development of antimicrobial resistance genes, then antibiotic degrading enzymes, then antibiotic altering enzymes, and then they acquire also this resistance genes by ways of conjugation or transduction or transformation from other extracellular environment or from the other resistance bacteria. So this is how the resistance develops and spreads. I was speaking about the conjugation, transduction, transformation. Transduction is the resistant genes get transferred by means of a bacteriophage, that is the virus that infects the bacteria. The means of a bacteriophage, the resistance passes. The means of a conjugation, that is means of a conjugation tube or a sex tube, the resistant genes get transferred from one bacteria to another. Or means of transformation, that is the resistant genes are released into the extracellular environment, and from the extracellular environment, the other bacteria acquires this resistant genes. So this is how the resistance spreads by means of conjugation, transduction, and transformation. How does this resistance develop? Because of the misuse of the overuse of antibiotics that plays a substantial role in the emergence of the resistant bacteria. Although resistance is a natural phenomenon, the proportion of the resistant bacteria multiply when antibiotics are used carelessly. Millions of people take antibiotics unnecessarily. Antibiotics have no effect on viral illnesses such as colds, flus, and sore throat. Use of antibiotics to feed the animals and the livestock is also a major factor. Animals can carry also the harmful bacteria from in their intestine. The resistant bacteria can spread to the animal products through contaminated food and water, or through contaminated surfaces, and all through animals' poops. The, then people get exposed to this resistant bacteria when they consume those contaminated food and so on to the contaminated environment. And some resistant infections then cause severe illness or mild illness. About 1 in 5 resistant infections are caused by germs from foods and animals. The goal of the stewardship program is to reduce the antimicrobial consumption, improve the patient outcomes, increase the adherence of treatment guidelines, reduce the adverse drug events, decrease or limit the antibiotic resistance, and reduce the healthcare cost. The Association for Professionals in Infection Control and Epidemiology is EPIC. Uh, always have put up in mnemonic for before to consider before antibiotic prescription. That is ABC. Ask whether it is necessary. Bacteria don't give for viruses, give for only for bacteria, and have a complete course. That is C. So this mnemonic ABC needs to be answered while during antimicrobial. What we did in our healthcare setting is that we introduced the resort antibiotic form, wherein the clinician was asked to justify for the prescription of the high-end antibiotics or the restricted or resort antibiotics like colistin, pulomyxin, digoxin, and others. Those reasons, and ensured we spoke to the drug therapeutic committee members to ensure compliance towards the resort antibiotic policy and have compliance to a rational prescription of antibiotics. Why we did? We had a pre-authorization of the broad spectrum antibiotics and prospective review after 2 or 3 days of treatment that formed the cornerstone of antibiotic stewardship program to ensure that the right drug is prescribed at the right time for the right diagnosis. Antibiotic resistance, what we should know is actually they never use the this for the educational matter for the community population that use the antibiotics mainly when prescribed by clinicians. Always take the full prescription, never is the leftover antibiotics, never share the antibiotics with others. Prevent infection by regularly washing the hands. That is hand. Break the chain of the infections, that is from the agent, host, and environment. It involves all the healthcare professionals. So, ensuring employee health, rapid, accurate identification of organisms, environmental sanitation, disinfection, proper attire, hand hygiene, following transmission-based precautions, following environmental hygiene, catheter cares, catheter cares of the devices, aseptic techniques while doing the invasive procedures, recognition of high-risk patients. There are multiple things that needs to be followed to break this chains of infections. Follow hand hygiene at the 5 moments of hand hygiene, that is before touching a patient, before any procedure, before and after touching a patient's surroundings. Well, which are let us see about some of the resistance to the gram-positive organisms. MRSA is the highly been reported from from clinical isolation in Indian settings, with rates as high as 54%. There have been reports from various parts of India, and the 2016 Indian infectious disease treatment guidelines recommend glycopeptides vancomycin ticaprane as the first drug of choice for MRSA. Many of the vancomycin resistance in MRSA have been observed and been reported, which were readily susceptible to glycopeptides like vancomycin. Staph aureus strains which were resistant to vancomycin were termed as vancomycin resistant. Staph aureus, the IDC guidelines recommend the use of alternatives such as high-dose daptomycin with other antibiotics such as gentamicin, rifampicin for the same. Then we have cases of vancomycin resistant enterococci. Apart from the UTI, enterococci can cause bacteremia, endocarditis, and other such infections. Enterococci, when resistant in vancomycin, are termed as vancomycin enterococci. The IDC guidelines recommends high-dose ampicillin for VRE strains and daptomycin monotherapy in serious VRE infections, and nitrofurantoin for UTI caused by VRE strains. Drug resistance has also been reported among Streptococcus pneumonia. Prevalence of macrolide resistance upon Streptococcus pneumonia is variable and is continuing high. The IDC guidelines recommend fluoroquinolones or a beta-lactam alone or in combination with a beta-lactam inhibitor along with doxycycline for macrolide resistant Streptococcus. There are quinolone resistance has been reported in gram-positive bacteria. While fluoroquinolone resistance is deemed to be less than 2% in Streptococcus pneumonia, 2008 studies reported that where fluoroquinolones were used to treat tuberculosis in children, there was the emergence of pneumococcal disease, which is non-sensitive to levofloxacin. So, even in the COVID-19, the microbiology documented secondary infection was diagnosed in 10% of patients. Among the patients with secondary bloodstream infections, the median time to detection was about 11 days. The major bloodstream infection was caused by gram-positive cocci, and while among gram-negative pseudomonas erythema was the common culprit. Among patients with secondary lower respiratory tract infection, the median time to detect lower tract infection was about 16 days. Lower respiratory tract was most commonly caused by Pseudomonas aerogenes. 50% of COVID-19 deaths experience secondary bloodstream infection. And medicine resistance was also reported. Vancomycin was used as the empirical therapy for the gram-positive bacteria if secondary bloodstream. So antibacterial choice is often complicated by multi-drug resistance. Many ESBL producing organisms also experience AMC beta lactamase. In addition, there is also an association between ESBL production and fluoroquinolone resistance. That's an ESBL may be, that is extended spectrum beta lactamase, may be because of SHV, TEM, CTX, OXOR, AMC. There are strategies to detect ESBL, as we can see from the present slide, where cefotaxime and cefotaxime plus clavulanic acid, when used in combination, can help us to detect the extended spectrum beta lactamase. An increase in zone of when used in combination of more than 5 mm helps in detection of the ESBL. There we also see an increase in resistance towards carbapenem. Emerging problem in Pseudomonas, Acinetobacter, and Enterobacteria is the carbapenem resistance. It severely limits the treatment options, especially in long-term care. Mediated carbapenems such as KPC producing cells of Clathraps and pneumonia. Then it's endemic in many locales in the US also. Its countrywide outbreak have been reported from Colombia, Israel, and it can be detected by modified Hodge test using usually they are ertapenem resistant and easily spreads in the. Other isolates of antibiotics such as Salmonella species and Proteus mirabilis and isolates of Pseudomonas also produce ESBL. However, at this time, methods for cleaning and fermentation of these isolates have not confirmed. So during outbreaks of such infections, the draining infections must be kept covered. Talk to the clinicians about the wound management techniques. Wash hands frequently with soap and water. Avoid sharing the personal items. Wipe the objects with disinfectant, and advise the healthcare workers about hand hygiene. The hospital pharmacist plays an important role in antimicrobial stewardship program along with the ID specialist, clinical microbiologist, and an intensivist. Each of them has a clear roles in the antimicrobial stewardship program. For example, the clinical microbiologist role is to have a rapid diagnostic test delivery, interpretation, and sensitive testings, along with the antimicrobial drug selection guidance. It is important to measure outcomes such as the reduction in the ESBL prevalence, decrease in the pan-drug resistance, increase amount of resistance among Pseudomonas and other such. And then feedback mechanisms needs to be provided to the clinical stakeholders. Contact precautions such as wash hands, wear gown and gloves needs to be followed as contact precautions to prevent the transmission of resistant. Diagnosis towards needs to be stringently followed, that is, modifying the process of ordering, performing, and reporting diagnosis tests to improve the treatment of infections and other conditions. There's a close relationship between the diagnostic stewardship and antimicrobial stewardship, where diagnostic stewardship is test centric or diagnosis centric, that is, right test for the right patient at the right time. Antimicrobial stewardship is drug centric or pharmacy centric, where it needs to have right interpretation for the right microbial and at the right time. There's a close relationship between the patient, the healthcare provider, and the diagnostic laboratory in this cycle. So there are steps at which diagnostic may improve testing. For example, there needs to be followed the general principle for pre-analytical during ordering and collection and storing, during processing in the analytical phase, and during reporting the post-analytical phase. There are guidelines for urine culture, blood cultures, cross-identification testing, molecular testings, and forms of automations and clinical educations. You can refer to the article Morgan et al. JAMA 2017 publication for the details of the steps of diagnostic stewardship. So in conclusion, secondary bloodstream infections and lower respiratory infections in patients with COVID showed a high degree of infection due to gram-positive pathogens such as MRS and VRE during the COVID pandemic. Patients with respiratory failure, severe lymphopenia, and early need of ICU were shown to be at high risk of secondary infection. The development of drug resistance in gram-positive organisms is a serious problem, such as MRSA, VISA, VRSA, VRE is alarming. Steps such as restricting the use of antibiotics and stewardship program needs to be enforced strictly. Increased push towards development of newer antibiotics against the gram-positive bacteria with novel targets is a requirement. Thank you to the references.